All right, so this session is nominally titled Measuring What Matters. What is it titled? Yeah, Measuring What Matters and Building What Counts. But you know, as you've seen from yesterday, the nominal title of the sessions and what people talk about are not entirely correlated, and it will veer off too. And we started this conversation yesterday, you may recall, yes, quite a spirited way. So I'm sure we will be spirited today. I'm not going to introduce this topic because it's been brilliantly introduced already by Vicki. I'm going to very briefly introduce the panelists, and I'd like to apologize to them now. Obviously, yesterday was business class seating, and now they're in coach. I don't know. And the asymmetry, I have no idea why one is higher than the other.
We just sat on what was here.
Exactly. Farah actually was going to order a drink, so it looks like a bar stool, so what the hell. Anyway.
That would be a really fun conversation.
It would. Yeah. We could do some science here. You know, half of them drink and half of them don't, and see who's smarter.
Especially if you've had the drinks.
Exactly. So I'm very quick on the introduction. I'm not going to reintroduce Vicki. Welcome back, Vicki. And you met, and you all know Jennifer as well. The two who haven't been introduced are Laurie Goldsmith, who is assistant professor at Fraser University. She's not only a health researcher and evaluator, but also teaches policy. So perfectly good fit for this conference. And to my immediate right and your left is Farah Shroff, who's an adjunct professor at UBC, an expert in health promotion, and has overseen and evaluated some of the some massive health, relatively large health promotion investments in the BC area. So again, a perfect segue from yesterday. Same format. We're going to try to cut this short, but we're on catch time now, which has nothing to do with what the schedule says. So we'll go till how we go. So I'm treating right now until 1:30 as kind of flex time. And we'll see how that goes. So again, the openers are supposed to be very short, 1 to 2 minutes, and then we will get into it, and we will again throw it open to you as quickly as possible. In fact, I'm going to throw it open to you earlier, so pay attention. Vicki, why don't you start?
Okay. Can you hear me? Okay. 4 points for each of the areas we talked about, building and then measuring. As far as building, I think that you need to build an infrastructure. When I first thought about this, it was build the infrastructure to conduct the research and data analysis. And then also build or identify the right metrics, because that becomes an issue. Building the right partnerships, which is probably the hardest and takes the most time. And then building the data repositories, because you know, you'll need where that massive data is going to be, so building data repositories. As it relates to measuring what matters, you know, the EMRs that we have, and someone talked about this the other day, and there's some current administrative databases. They're not built for the information that we want to look at. So you need to look at how you use those. They can be used because that's what we have right now, but looking at that. And then measuring what matters, it depends on how you enter the data, so data validity, making sure that the data is valid, making sure that you have looked at how everyone enters it, how they define it, is key and important. And then the last thing that I'd like to share with you, and I did not say this earlier, and someone mentioned to me at the break, what a great relationship we have on a national level with our national agency. From your perspective or his perspective it was. And I would say that partnership is key. We do enjoy a great relationship with our federal agency, the Bureau of Primary Care, that administers the health center program, as well as our National Association of Community Health Center, the state and regional PCAs, and the health centers. In fact, the Bureau of Primary Care provides funding to some level of funding to the PCAs and the National Association, you know, some level of funding, so that we can provide the services that we do to the community health centers. Now, it's not full funding, but they have committed by the resources and also the relationship.
Thank you.
Thanks. Well, I think I'll be fairly short, because I've grown up in CHCs, and I think my passion and what fuels me is measuring what matters and getting our clients and our community stories told. And it drives me crazy when I see research and it doesn't include our client stories, and especially population-based research. It just drives me around the bend, and it's really what's fueled me to do everything I've done. You know, I remember being at a public health conference, and they were presenting diabetes data and poverty in Toronto, and it didn't include the CHCs, and I just went nuts, and I called the scientists and I said, "Do you realize that you've missed the most important people?" And so that's what really fuels me. So when I think about measuring what matters, that's what matters. We need to get our stories told and really reflect the health status and the reality of our communities that we serve. So.
Great.
Thank you. So I think it's helpful for you to understand where I come from as an academic. So even though I'm interested in improving the health of populations and social justice, I'm predominantly motivated by measurement and methodology. And when I first joined Simon Fraser University in 2007, the Canadian Centre for Policy Alternatives had a little bit of extra research money, and they said to me, would you like to use this money and leverage it for some more money to study community health centers in British Columbia? And I was relatively new to British Columbia, and I said, sure, sounds interesting. I'm interested in organizations and how they help with access to care. So tell me what you know about community health centers in British Columbia. And I was told there aren't very many. So I started doing some poking around and found a list of 26 community health centers that was on a website for the then defunct BC Association of Community Health Centers. So I took this list to the advisory committee that the CCPA put together for me. I said, well, 26 seems like a fair number, not only a few, and was immediately told, well, those aren't all true community health centers. And my spidey senses went off, and the methodologist in me got really excited. What do you mean, true community health centers? And that started a conversation that unfortunately got interrupted in my life by 4 years of illness, so I'm still trying to wrap my head around this conversation. So any help from the audience I would appreciate. But that started a conversation around what is a community health center? And I think that is a conversation that this group needs to have very, very seriously, because there is a variety of definitions of community health centers in this country. There's the Ontario-Quebec experience, where there's a direct funding source that very clearly defines community health centers, so that's quite similar to the US experience. Then there's everywhere else, the Wild West and the Wild East of Canada, that sort of anything that wants to call itself a community health center is calling itself a community health center, and there's varying forms of agreement about it. So I think before you can even get to measuring issues around community health centers, there needs to be a really clear conversation around what is the definition of community health centers. I'm trying to help with that with my work in BC, but I'm also getting villainized by some members of the community in British Columbia. And I do want to also make a plug for most researchers are trying to add clarity to the conversation, even if what they're saying doesn't agree with what you want to be saying. Sort of try to work within that clarity. And I'll leave it at that for now.
Bonjour tout le monde, je suis de Vancouver, alors je dois parler en français, spécialement pour les amis francophones qui sont ici. So I'm going to talk a little bit what I'm calling celebrations of our accomplishments and journeying forward through transformations. I wanted to first acknowledge that we're on the land primarily of the Cree people, and to say thank you to them for the beauty that is here. It is really beautiful. Although we can't see it in this room, the river is really gorgeous here. And I also wanted to say how special it is to be in Saskatoon for this really special 50th anniversary of Medicare. I think it makes perfect sense that Medicare started here, that the people of this province, the settlers of this province, have a long tradition of knowing how to share through cooperatives and through their farming culture, which persists today. And I do think that Saskatchewan continues to be the leading edge of healthcare in Canada, so it makes a lot of sense to be here. I also want to say that really one of the main reasons we're here, or should be here, is to celebrate. This is a big celebration. It's a massive accomplishment that we made it to 50. 50 is a big age, isn't it? I know some of you have probably celebrated your own 50th birthday and probably had a good time doing that. So here we are celebrating the 50th anniversary of Medicare, and we've had a lot of challenges to get here. So I think some of the things that we really want to do at this conference are really celebrate that well. And to recognize that Medicare now, after 50 years, is so deeply rooted in part of our psyche as what it means to be Canadian. It really is as big as hockey. And as a hockey mom, I don't say that lightly. And celebrating the fact that CHCs are under the umbrella of Medicare is another celebration. And I think that CHCs are also one of the most important accomplishments of Medicare in the past few decades. So I think sometimes we as Canadians aren't very proud of the things we've done, and that's part of what makes us great as Canadians, because we're so humble. But let's be a little proud of this one. One of the other things that I think we really should celebrate under the umbrella of Medicare is the introduction of midwifery care. Midwifery care has this model that is so consistent with the way that person-centered or people-centered healthcare works under CHCs, that it's just worth mentioning that the woman-centered care model, which is based on spending time with clients or women, choice of birthplace, informed choice, continuity of care, all of these kinds of things are a big celebration, especially because they were embraced by Medicare in most jurisdictions quite recently. It shows that Medicare can be adaptive and it can be intelligent in meeting the needs of this generation and future generations. So here's to a continuing evolution of Medicare, because what we need, I think, after our celebrations is to get back to work and work differently and a bit smarter. When we started Medicare, Canadians were 27 years of age on average, and now we're 47 years on age on average. An acute care system worked for us then, but now a lot of us are living with chronic conditions, and many of us are living with multiple chronic conditions. We need to transform this system. And the work that I do really makes the argument that we need to shift paradigms. We need to shift paradigms towards a more integrated, comprehensive, patient and people-centered healthcare system, which all of you actually put into practice most days in your work in the community health centers. So for the rest of the healthcare system, this means a real change in form and truly trying to meet that triple aim of better health, better care, and better value. Moving upstream, doing health promotion and disease prevention, and I think innovations need to be part of this. So I just want to talk a little bit. Okay, I'll be real fast.
You got 30 seconds. That's it.
30 seconds?
Yep.
I wanted to talk. Okay, I'll tell you what I wanted to talk about, and then Stephen's going to cut me off. So I wanted to talk about nurses as the driver
Cal left
of
that
change.
barn a long time ago. Go
what's
ahead.
that?
Go ahead.
What? Can I finish?
Yeah, yeah.
Okay.
Yes.
So, okay, I know there are a lot of nurses in the room, so I really wanted to put a shout out to all of you, because nurses are the people who make this healthcare system really move. And without nurses, we wouldn't have a healthcare system. And so thank you, nurses. Nurses do save lives. Doctors are great too, Michael. Thanks for standing up for yourself there. I know there are a few other physicians in the room, but I really do want to talk
real
about
doctors,
nurses
Michael.
for a moment. Nurses are the largest healthcare provider group in the world. They provide care 24/7 that saves lives. And most nurses could be working more towards their full scope of practice. And they are key to transforming healthcare from within. Nurses...
Can we please?
Okay. Stephen, really, do you want me to finish right
I
away?
do.
Okay, so then I can't
I ain't
tell you...
making this up, yeah.
So, okay, I can't tell you the rest of my talk, because I wanted to talk about holistic healthcare, a teeny bit about the social determinants of health, and about how CHCs can lead transformation. So I won't tell you all of those things, because Stephen's really cutting me off now, but I want to tell you...
Yeah, really. Let's hear. Thank you
okay.
very much. I know you were getting to measurement at some point, but I was no longer certain that this was the case.
I was.
I just would say that, you know, it's now that Saskatchewan's rich, we've left that cooperative caring part behind us, so don't go praising us for that anymore.
That's true.
Okay, so here, one of you, please, to take this. And all right, so resuming the discussion of measuring what matters, and I think Farah has told us a lot about what matters, and perhaps we will now turn to how we're going to measure it. So there is a measurement challenge, and it's been implicit and explicit in what people have said, both today and yesterday, about, so what are we doing on standardization? What is the movement going to do about getting on the same page? So in the States, as Vicki can tell us, the comparative effectiveness research movement has been a big advance, I think. It's been the unsung triumph of Obamacare, or the debate surrounding Obamacare. At least the investment in that has been a really, really solid thing. We have challenges such as when you have a movement like this in community health centers which want to make a difference in people's lives, not just in a broad way, but over a long period of time. It's very hard to measure tangible outcomes over a long period of time with the attribution issues and so on. So those of you who are in the trenches of this measurement and analysis, what do you think the biggest challenges are for the CHCs to make a leap forward in what Vicki mentioned this morning? You know, we not only have to be good, we have to prove we're good, and we have to have hard data, combinations of qualitative and quantitative. So with all the challenges in the messy world you live in, where are you the most optimistic that we're going to make headway, and where do you think the biggest challenges are? So
maybe I can just, back in 2000 in Ontario, we thought about who we were as a program, and it was sort of getting to that definition issue. And do we have enough in common to even be considered a program? And we developed what we called an evaluation framework, and that drove then some mandatory data elements. And we've, 15 years later, 13 years later, we're now sort of revising that and calling it a results-based logic model, and we're furthering sort of our data collection. And what that's given us is the sort of power to tell the story simply but powerfully as a sector in Ontario. And I think, to me, that's the biggest challenge. And that was sort of my thought with some of that organizational data, because we didn't even know the types of providers people had in CHCs or what they did. So for me, that was the first step, and I think that would make us so strong if we could just have 50% of us couldn't even tell the proportion of males and females in our CHCs. Like, we just need to get some basic core data elements to be able to describe the story. And I think another challenge, I work so much with provincial data sets, or Ontario data sets, and the fact that all of these data sets are siloed in Canada, it's really tricky, because I realize it's just simple, very basic data, but with that basic data we can tell some real stories. So I don't know if I don't think there's a solution around that. I don't think. Maybe somebody else has a solution, but I think if we as a sector, as a Canadian sector, can start coming up with just some simple data, it's been so powerful in Ontario. So that's.
And just I'll get you in a sec, Farah. On Vicki, you mentioned this morning in your talk about we have these big administrative data sets. They are what we have, so we mine them. Mm-hmm. And then there's the potentially richer mother lode of when you can design your own and collect your own data. And there's a trade-off, of course, right? What's there is ore to mine, otherwise you're looking for a new mine. In your experience and in the American experience, where does the case making get advanced the most? Is it in creative use of the administrative databases we have, which you've worked with and so on, you too? Or do you have to at some point bite the bullet, find the funding, put together some new data sets, and work with them?
And that's exactly where we are. It has served us well, those administrative databases, but you kind of get to a plateau place, because after a while, your policymakers, or whoever you're making the case to, and I don't just mean legislatively policymakers, because there are other levels of policymakers, but whoever you're making the business case to at some point is going to want to know more. So if you're consistently giving them what you have, which has been great, you still get to a point where, and I think that's where we are now. We've been able to tell this story and it's worked well for us. Now we need to expand it, or we need to drill down, and that's why we need to look at the building our own, or as you just said, we need to look at what we have and then defining that and come up with some core elements. So now we're looking at core elements that expand on what we have and getting everyone to the table to decide on what those are going to be and how we're going to all measure them.
And do you build them in? Are you trying to eventually, is the plan to build them into your EHR or some?
Yes.
Okay.
So having that dialogue is a whole nother conversation as far as that place of where it is placed and where you put it in the system, so that you can get out what you're actually putting in or you think you're putting in. And then that involves a discussion with the vendors, which is a whole nother piece.
And I'll just add that we actually did that in Ontario. We've got our mandatory data set. We've incorporated it into our EMR. But our problem was the CHC data, we always sort of protected it and we kept it close to our heart, and we didn't include it in, it's not included in any of those administrative databases. So we've had to sort of do this leapfrog over all of the bureaucratic nonsense and get our data in. And so it's been an interesting process because I think there's power in both, but just having that knowledge set of what we need to collect that describes us has been really important.
I just want to say that in combination with doing that kind of data collection and having EMR that collect that data, that evidence has to be able to come in a package with a good political program that moves the research forward. Research alone usually doesn't help a profession or the community health center movement move forward. It has to come together with some pretty smart political talk. And I think Scott was talking about that earlier. So research alone, unfortunately, hasn't helped very many professions move forward. So I think it is important to put those together with some good political lobbying.
So, and there's already been lots of good things put on the table, so let me add to them. I think one of the weaknesses that I've observed in the CHC community is that to be able to do good research, you're going to have to counter your instincts of arguing from your place of passion. Your place of passion is really, really important for your patient care and for keeping your community alive. But if you start off arguing from that position of passion, you will turn off a large proportion of the research community. You need to be speaking instead about what data you have, what interest you have in finding out answers to particular questions. And that has risk. You may find out that some of what you are doing is very flawed. You may find out that some in this community are doing a very poor job of taking care of their community, even though they think they are taking good care of the community. So you have to be willing to live with that risk to be able to have a broader conversation and to be able to move to finding better what you think is working, how much better it could be working, and what is not working. The flip side of that is that your passion is very important. It will pull you through the difficulties of research, the difficulties of building the data sets. It's hard work. It takes time, it takes energy, and so your passion will help you there. You also need to resolve this conversation around governance. From somebody who is sitting from the outside, it just looks like petty infighting, and it doesn't make it look like an attractive community to work with as a researcher. Despite the passion. Like, the passion is attractive, but this concern around governance, to me, as an outsider, sounds like you're fighting over something that I don't have enough evidence is worth fighting over. Give me some evidence that it's worth fighting over, then it makes sense to fight over it. But with the dearth of evidence, just makes it sound like it's petty to an outsider. So hopefully I am not getting myself disinvited with that statement.
Yeah, so hold on one sec. We're going to continue. Please feel free to come to the mics. I do have another question, but I don't need to ask it. So if you get there first, you're in.
So I think that points to what we were talking about earlier, is that doing research on CHCs can be done in two ways, by having academic partnerships as well as building in-house research within CHCs. And both of those are really important to do. Probably more importantly, to build capacity within CHCs is going to help the research agenda move forward. But in terms of working with outside academics, I think Vicki alluded to how important building those relationships are. So Laurie's talked about some of her experience in working with some CHCs. I see research just like any other enterprise. It's about building those relationships, getting to know each other, finding the researchers who are right for the kind of passion that you have.
John.
I'm John Berry. I came here 50 years ago to join the community clinic as a physician. I retired 25 years ago. There goes the century, but I still am interested. I think I actually rather I'm happy for America being stagnated about healthcare, because we're not stagnated, we're going down. We're being Medicare is being attacked because it's inefficient, it's not sustainable, it's not efficient, and unfortunately, some of the criticism that is brought to us is being brought to us by what I would call the conservative and corporate elite. We share. The community clinic in Saskatoon is rather different to most of the community health centres we've been talking about. What brought people together to find our clinic was the defence of medical care insurance. That's why we came together. So our patient group is a very widespread one. We have, ranging from millionaire farmers who thought they were social democrats to university professors who used to meet in the liberal professors who used to meet in the crop store. You don't do that anymore since the university became corporatized. But we had a very wide range, and we still do. And our West Side clinic is dealing with the group that most of the, I think, health centers are dealing with. But our main downtown clinic is dealing with a middle class, and the middle class continue to come to the doctors. We can demonstrate that we could give a good level of primary care, but here is a new data set that we may be looking at. The majority of people are still going to doctors for a variety of reasons. Do we know what those reasons are? What are the determinants of health for the middle class, which is, after all, the majority of the population? Is it the stress of here that you can't get good childcare? Is it because of the stress of the lack of elder care? Is it because of stress about paying for higher education? Is it because that middle class is getting diminished and is being faced by the income gap and is no longer secure? Is that what drives our patients to the counselling department? We have a huge counselling department, most of which come from our east side, well-to-do clinic. What are those stresses? I think we have a great opportunity with the clinics in Saskatchewan to investigate that system, because we may find that those stresses are costing money in our necessary health care. If we could do that, we would get a large people on our side. And I'm suggesting this is something we should seriously look at, because if we don't, we do need to persuade our masters that we're doing some good, and we need to know that we're doing some good for everybody, not just what we call disadvantaged groups, because you're doing tremendously for disadvantaged groups. But I would like to see we're doing tremendously for not disadvantaged groups, which after all are the majority of the population.
Thank you, John. Thank you, John. Please go straight to you, Michael.
Yeah. Thank you, John. Michael Ratcliffe, one of the questions I was going to ask, it sort of follows up a bit on what John was saying, which is that I don't know what evidence you've got on this, so I'm going to throw it out to you, and I'm interested in what happens in the US, but I'm struck by the fact that while probably the most innovative things you can find in this country in primary health care are in community health centers, you also find some very traditional kinds of practices, as John mentioned, going to see a doctor every 2 or 3 months and getting your blood pressure taken or something. And I mentioned this yesterday. I didn't provoke people, so I'll just throw it out again that I am struck by the different models, the way that teams are organized. And so I'm just wondering, what do we know about care in community health centers? Is it really that different? Is it using peer support, behavioral change, community interventions, and then your point care is from a nurse as you need it, and then the doctor's in a closet you bring out when you need the doctor? Or is it that you go to see a doctor every time you have a visit, and then maybe you get referred to somebody else? What do we know about what's going on in that terms of model of care within community health centers? How different is it from traditional care? And what evidence is there of what provides better care?
So the short answer to that, Michael, is we don't really know. There's not enough documentation. So in 2007, I did a systematic literature review and basically couldn't tell you very much about what was happening in community health centers as distinct from other models. There was a little bit of literature from Ontario. There was gray literature, so it was findable on the Community Health Center Association website, but wasn't published in the peer-reviewed literature. The situation has changed more in Ontario. There's been more of a push since 2007 for more research, but it's still, basically, there's hardly anything out there that is identifiable as community health centers. So that is a call to you. Get some research done, more of it into the peer-reviewed research literature, because that's also a way to get more researchers to pay attention to your communities. It's also another way to speak to health policymakers of all types. So Jennifer and others in Ontario are certainly leading that charge, but it's not good enough that it's only happening in Ontario, and it hasn't been happening for long enough yet.
Vicki?
The CHC model in the U.S. actually uses, well, the model includes what we call the mid-levels, which is the nurse practitioners and the physician's assistants as providers. So we count physicians, nurse practitioners, and physician assistants as providers. And it depends on which health center you're in as to who is the lead and how many of each that you have. But I will say this, I have not seen the research that says that one model is better than the other just by virtue of it being a type of provider or not. There are other factors that come to bear then on the success of those community health centers, but we are very much engaged in the model of using providers, physicians, nurse practitioners, and physician assistants.
There's a wealth of peer-reviewed literature that does talk about the need for more collaborative care, the need for more interdisciplinary care. There's a wealth of literature that pokes holes in the current healthcare system as it exists. So drawing upon that literature would be quite an easy call. And once there is this research movement that starts in CHCs, using that literature to make your case better would certainly be a great way to start. So there's a lot of groundwork laid already for CHCs to start building a foundation upon.
All I was going to say is that what's happened to us in Ontario is one question kind of leads to the next. So we did a comparison of model study, and then I worked on a panel size study, and what begs the question is, well, boy, why are we different? And so what we've sort of hypothesizing is, well, maybe it's interprofessional teams. So the next project that just has gone through ethics is we're looking at the role of interprofessional teams. We're looking at, is there sort of an ideal team mix? What's the scope of practice of teams, and how does that all impact outcomes? And I think part of the thought I had was we also have a performance management committee in Ontario that sort of tries to drive strategic questions. And so it always, I think that's something that maybe we could do. I was thinking about that with CACHC. Like the CACHC Research Working Group has a bunch of researchers on the committee, but I mean also, I hope we're somewhat strategic thinkers, but I also think it's maybe important to have some of those bigger, like we've got our noses in data and research questions, and it would be interesting to have some of that strategic discussion at that group, because I think it's important, and it's what's really moved some of the work forward we've done in Ontario. So if we could sort of have that bigger picture, it would be helpful.
Cheryl Hand, I'm from Westside Community Clinic here, and I guess I just want to talk about some of my frustrations around the research, because everybody wants to research us at Westside. We've got this large Aboriginal population and this huge, with the HIV epidemic going on in Saskatchewan. But most of the research is basically kind of the students come in, they all want to do research project. Everybody wants our data because we're right there and everything else. But to be honest, we haven't even got out of it that primary health care is one of the best ways to deliver HIV care. It hasn't come out of it. It's just all, and the community I work with are so tired of being researched. They say to me, like, everybody comes in and tells us we've got a problem, but nobody comes in to do any action. I mean, it's all, and stuff like that. So I don't know whether anybody else is having those kind of frustrations. And when you were talking about, your database around things like that, with our introduction of our EMR, I used to know how many male and females came into our clinic. I don't even know that anymore. I don't even know the demographics of the age anymore. I used to know that on our old health suite. We haven't been able to figure out how to get it from our EMR. The government is telling us, don't worry about collecting that or handing in reports. It's not a big deal. I'm not sure I trust that, you know what I mean, to be honest, because it seems to me it is important to know who we're seeing, what we're doing, and some of that. So I guess my frustration is that a lot of the research that's being done, particularly in Saskatchewan, or at least that comes to us, to the clinics in Saskatoon, is kind of their projects, and it isn't necessarily ours, and that doesn't really promote the CHCs or primary health care or any of that work. So I don't know how and yet we want to look like team players. Like if you start saying, no, we aren't going to take that, then, people will say, well, this specialist comes here, or this person's working, this is part of, importance to the college doing the research and doing all this. So it's a hard balance to play when you're how to handle it.
So hold on, before you go, So what you're saying is that reacting to others' research interests and
Yeah.
being sort of the community for the anthropologists to come in is a little irksome. But do you have your own research-oriented questions, and do you have a process for generating your own agenda so that maybe you can shop that out to partners instead of just having to, beat them off with a stick?
No, which was likely something I was thinking we need to do. Maybe we should be saying, when they come into research, okay, then you need to say back to us. But to be honest, by the time they get through to us, they've been through the health region ethics, they've been through the university ethics, and the time they get to us, they can't change the questions without having to go back, through all that. And then they say, we've got this timeline, and, it's, but that might be something to try to figure out a way to get what we need added onto it,
So I want to say two things really quickly about that, and then we can push it back to the audience unless someone else here wants to say something. So one, I want you to make sure you distinguish between research that is being done on the populations that you serve, so you're a convenient source of data, which was just being described, and research about your model, which might make more sense to be driven by your community. The other thing I want to throw out there is that you might want to take a page from the book of the First Nations community in Canada. They have pushed back against that movement of using them being used as data sources, and now say, no research about us without us. And they insist on community-based engagement of all research projects. And so that phenomenon of the research question being identified after ethics, after all the work has been put in, is no longer able to fly if you do any First Nations research in Canada that has any connection to the community at all. So study that and push back against people just using you as a convenient data source.
And it goes back to the relationship, because when you have someone coming to you and here's the plan and this is how we want it, and this is your first time really developing the relationship with you, the expectations on either side are not written out. No one knows what to expect of the other. So you're gonna end up having those trials and those issues where it may or may not go well. So the relationship is key. So be proactive in any questions that you may have, reaching out to your academic partners so that you can develop the relationship. And then the no research without us, another piece that you need to recognize that can be subtle, even though you say that, and sometimes your academic partners truly want to do that, because they don't understand the system, they may not always actually, what they intend may not be what actually happens. So it still may have gone through everything, and they're coming to you going, well, I'm engaging you now. No, engagement means when you have the idea before you go through any of those steps, let's sit down and talk. And let's understand it before you even go through any of the academic approval. So that's very key.
I think it is completely possible to have a win-win relationship between CHCs and academic research partners. And it probably means that CHCs need to set their own agenda and say, this is what we want research done on, and this is how we'd like it to happen. These are our questions, and if you're able to help us answer our questions, then we welcome you. Because students usually have a really wide possibility of projects that they can do, and they sit down with their supervisors or professors and cook up a question. And it doesn't usually have anything to do with what you want. So if you actually tell them before they come to you, this is what we need done, it's actually quite possible that you could get that to happen. And that usually happens before a student comes in to do their practicum or something like that. The timeline needs to just be a little bit longer, usually. But I see it as perfectly possible. I've been engaged in doing campus community partnerships for a long time, and it's often a win-win situation. But the communication has to really be very, very clear. Otherwise, research can be a form of exploitation, like it has been on First Nations communities, and that's why they've stood up and said, we don't want this anymore. It's not helping us at all. The action doesn't follow after the research. So, yeah, I think it's worthwhile learning from those experiences.
So, this is on, right?
Yeah.
In Ontario, the Performance Management Committee, and I thought Jen might mention it herself, is that committee did develop a research strategy exactly for that reason, that we did not want to be a subject matter for somebody else. We wanted to participate in those research questions, designing them, developing them right from the beginning. Mind you, we still look for the appropriate partners, and there's a committee, and that works on that and brings it forward to the performance management. One other thing I wanted to mention, and as the esteemed physician who was here 50 years ago mentioned, that there's something different about the CHCs and that it works better. And the ISA study that Jen was very much involved in absolutely said that something is going on over here, that in spite of a lot of complexities, the CHC clients, members, patients don't go to the ER as often. And that was the only thing, and Jen, you can, you know, you have all the research details on that. And so that should trigger the other questions. What's going on over here? Definitely questions around what is the team makeup like? But beyond that, what's going on? The diabetics with COPD and CHF is not going to the hospital ER as much as somebody from our family health teams and the others. And maybe not only because of the fantastic interprofessional care, but also about the good food box they're getting, their supportive network, and all of that. So I think there is some data, there's some light that is being shed on the quality of the care that is being provided, but it's, you know, what's the basket of services that people are getting at CHCs that is different. So I think we are moving towards that, and Jen is absolutely right. Each question, each research raises some other question, and you delve into that. And we don't have huge research money. So seeking out appropriate partners, so getting to those questions is very, very important. Just to remind people of that we do have some good data. The Elizabeth Breyer study, and especially in Ontario, we've done a lot of work. And how do we showcase it and put it in the right places?
Yeah. Sue Sutherland from North Lambton Community Health Centre in Ontario. I'd like to go back to Dr. Goldsmith's question, what is a community health centre? And I'd like to apologize for what I'm about to say to my new colleagues here from Saskatchewan. I went on the tour yesterday of both clinics, and I was quite impressed with what I saw and what I heard. However, it confused me a great deal. In Ontario, we have several different models of delivering primary health care. It is confusing, I think, to the public. However, it has shown the growth, I think, in Ontario from the early days when only a small proportion of our population were eligible to get comprehensive care through a CHC. And now the general public, as I will call it, can get care from a family health team, a family health organization, or a nurse practitioner-led clinic, etc. And the Ontario government, I think, learned from the CHCs that having a multidisciplinary team and health promotion programs offered a great advantage to the people who were getting their care there. What I heard, what I saw in the tour yesterday, and again, I apologize if you're offended, but I think your downtown clinic is operating like an Ontario family health team, and your West Side clinic is operating like an Ontario community health center. And it's a big distinction. And I'm not saying it's wrong, and I'm not saying that you're not offering great care, but it does lead to confusion across the country as to what is a CHC. And I mean, I'm impressed too with what I've heard from talking with people in Alberta and British Columbia about the co-location of dental clinics. In Ontario, there are so many people, because of income differences, that don't have access to good dental care. And what I heard about Vancouver, what they're doing is the folks that have insurance or who can pay, the revenue allows those folks who can't pay to have good dental care. And I think in Ontario, we could learn a lot about that. So this has been a rich opportunity to learn about our similarities and our differences. But again, Dr. Goldsmith, I'd like to see a much clearer definition.
So before you go, that's a very interesting observation. So is not to be indelicate, but is your uncertainty about what you saw that the main clinic is or is not, do you think, meeting needs as comprehensively and well? Or do you think it's just, it looks like a family health team because it's got a family health team like middle class population? Or are you saying something else?
I think because of the wide open, anyone can come, there's no criteria for a target population. And also because of the high number of physicians versus nurse practitioners.
Okay, thanks.
I think those are questions I've heard around many CHC tables, asking what is the identity of a CHC? Is the identity of a CHC to fill a niche, a really good niche, working with high needs populations? Or is the identity of a CHC to work with everybody? And those are questions which you have to answer yourselves in CHCs. I think that if the CHCs as a model are going to grow in Canada, then both are going to work. And I think it's hard with funding restrictions to do both. But I guess I would think that a community health center that serves a middle class population is still a community health center. So I would argue for a broader definition, the way that CACHC already does it, than a narrower one. I think that the survival of this movement is going to be enhanced by a greater ability to reach more people. And because the physician who spoke earlier said most Canadians are middle class, it does make sense to reach out to having a model of a one-stop shop, co-location of services under one roof, and more than co-location of services under one roof, referring to each other and working together. True interdisciplinary, collaborative, respectful care, patient-centered care.
And quickly, again, here I am as a methodologist parsing things. I think it's important to decide what's the reason you're coming up with the definition. Are you coming up with the definition to be able to decide who's in your advocacy group, which may be a different definition than the definition that is attached to funding, which may be a different definition from those you partner with to get things done. So you also have to decide what the motivation behind the definition is.
And I would say that in the U.S. that's a key point, because you do have, there's so many titles. There's the FQHC, which means that's tied to payment and how you're reimbursed through the public insurance. And then there is the health center, and then there is a community health center. But what I outlined earlier today is a broad enough definition that allows you to practice, well, to implement different models, but still within a certain floor for the definition or criteria of what a community health center is. And I think for our community health centers, very generally, it is to be the provider of choice for all in their communities. So it would mean that you are also taking care of those who cannot actually have access to health care, as well as those who can. So it is serving all patients or all community persons regardless of their ability to pay or regardless of any other special, populations they may fit into.
I think we can all agree that a middle-class CHC has to have a hot yoga studio in-house. Go ahead, Scott.
We actually have sitting that here as the guy who on a day-to-day basis has his finger sort of on the pulse of what's happening within, let's say, community-based primary health care across the country, and what labels we attach to that. I recognize, and I think most of us here would be that, this is a burning question around definition, and it's an important question to ask, and we need to continue. We need to allow a space for that to happen. We don't want to hide from that. We shouldn't hide for that. We need to have it on the table and have a conversation. There is a risk that we can carry that pursuit of a definition ad absurdum, though, and I think often we do. And let me give you the party line as far as the Canadian Association of Community Health Centres is concerned, that a number of years back, taking a look at the broader system and the true obstacles that are out there to advancing what we all believe needs to be the case when it comes to community-driven, community-based, participatory, comprehensive primary health care. The differences and the distinctions between a cooperatively governed community health center, a community clinic, and a not-for-profit community clinic, a community health center that is the service point of a regional health authority versus a not-for-profit or community governed, while valid, is infinitesimally less important than it is the bigger landscape of primary care out there, which is still the domination of fee-for-service medicine, and where there has been movement only to a narrow definition of team-based care, and really without engaging in vitriol and trying to overly stigmatize, pointing out the inadequacies of that approach, that business as usual approach to primary care. And so the association came up with a revised inclusive definition that creates a broader tent, and really what the focus is there is on vision and intention. And I think it's important for us to realize that what is, in the case of many health centers across the country that are included within our inclusive definition of community health centers, are reactions to an external environment and the desire of folks at the local level to do the best that they can within provincially determined or locally determined funding structures to deliver an optimal vision of what can be done within the limitations of what can be done. And so let's distinguish between vision, heart, personality, and those commonalities, and what ends up being the reality on the ground. I think when all of us, and speaking to folks from Ontario, for instance, when we talk about a community health center as labeled, as opposed to an Aboriginal health access center as labeled, as opposed to a community family health team as labeled, and so forth, when you get folks in the room, we're talking the same language. Different perhaps populations, different starting points, different priority areas of concern, but it's the same language. And there's a common vision for what needs to be done. There's a common vision of a trajectory. And I think that's what we really need to focus on. And I think give that some definition and be clear around that. But let's have that as the starting point. And let's talk about direction. Let's talk about vision. And if it turns out that a particular health center says, God, no, we don't believe that community-based services and enabling and having more than a physician-driven care team or physician and NP-driven care team is important, well, okay, they're not a community health center. But if the vision is there, but the funding doesn't enable that, there's a big difference between those. So I strongly encourage all of us to see that broader tent of community health centers as we define it as part of the family, as part of the network, and let's have practical discussions about how we all move together to that optimal vision of what needs to be done, how we address those external funding barriers, and recognize that what is a reaction to limitations, and is a reaction and is a step-by-step movement towards that vision. But this is an inclusive tent. It's a welcoming family, and I think we need to be clear around how we define that and how we message all of that. But from the perspective of our association, that's where we are. That's where we're going. And to what Farah just said, I think that is the most politically astute way and the soundest way to advance what I know is important to everyone here in the room.
I just want to comment, without sounding defensive, that actually I'm very excited that we can be in the same room and that people can stand up and say, you know what, I toured your center and this is what I think and I don't like this about it, or I'm questioning this and that, because frankly, those are tensions that we have within our organization. Two, I will admit, radically different models of care. One evolved out of the organization identified a community need that was not being met. That's how Westside was born, and that's how it's grown, it exploded in many ways, and one that evolved or was spawned because of the crisis of Medicare 51 years ago, and that grew in a quite a different way and evolved. And you know, these are actually questions that we're asking ourselves right now. We're entered into strategic planning process. We're doing many community consultations, including our members and patients and partners and that sort of thing. And these are questions that they've asked as well. They're saying, why is this different? And I think that's great. That is exactly why we're doing it, because we are community owned, community governed, and if we're not responsive to those questions, then we're obviously not doing what we need to be doing. We're not. So that's perfect. That's great. Trying to actually bring it back to what Stephen's trying to do is to talk about the measurement and why and how are we measuring, and certainly recognizing comments from Cheryl about being researched to death. I agree again that we need to set our own research agenda and make sure that we are in control, and we need to be strong enough to say no, we will not allow that to happen, but here's an alternative, because those are relationships that we've built and are building and are nurturing. And those are important relationships because we are a relatively small community. We have one university, and so those relationships are important because they are a source for us to actually draw on, assuming we can maintain and or grow the relationship. So those are important things that we need to do. Even Nazim that was here yesterday is a good partner in that. He's done some work along his own lines, and we need to go to him, I agree, with what our agenda is, and then he can seek out partners to make sure that happens. One of my concerns about the whole measurement thing, we are definitely on board with the need to do that in an evidence-informed way, is the comparison of the quantitative with the qualitative, and some of the numbers games that we do, the number of clients we see, that sort of thing, high risk or low risk or whatever, is the, I'll say, dearth of evidence and data there is around the upstream work that we know we actually need to do more of. It was definitely an aha moment for me a year ago when I went to AOHC, started asking questions and found that, oh yeah, we've got 3.5 FTEs of physicians and whatever, 7 nurse practitioners, and we're like this, and most other CHCs are quite a bit different. And so I started asking those questions as well, and you know, they've got more health promotion going on, that sort of thing. They're definitely more out there than we would see at our downtown clinic, that sort of thing. So one of our challenges is to provide the value proposition back to our funders, the ministry, so that we can prove that there's an ROI, there's a return on that investment. And I'm firmly converted, and I know you are, that does exist, but providing the evidence for that is still our challenge and will continue to be.
Thanks, Tim. So I just wanted to say, in terms of looking at the return on investment for the upstream work, CHCs are ideally situated to do that. And here we are celebrating the 50th anniversary of your CHC and some other CHCs in this province. So as long as you are going to continue to be around for a long time, upstream research takes a long time. It takes a long time to prove that health promotion and disease prevention actually does bear out in health outcomes. And that's why there's so little of that kind of research. So many of us have short-term research time horizons. So if there's a CHC that wants to do upstream work, and you plan it out for doing it even over a generation or longer, then you're going to be able to have some really good hard data to make your case. But that is the issue with upstream research. So as long as we're going to be here 50 years from now celebrating the 100th anniversary of Medicare and CHCs, that kind of research is totally possible.
I will quickly warn you that most prevention is not cost saving. It goes against the instinct. You want to look at the work of Louise Russell. Some work that I've done and others have done around cost effectiveness of prevention. Also, communities doing preventive work indicate that cost effectiveness work is traditionally used simply to disband their programs, not to support their programs. So moving too quickly into looking at the cost effectiveness of your prevention work may backfire against you.
Do you mean both primary and secondary, or you're talking primarily primary prevention?
I'm talking both primary and secondary prevention. So, you know, I'm happy to direct you to some reports that, but you can trust me. There's not a lot of evidence that is actually cost savings, because there is so much effort in delivering the programs over a long period of time that those costs add up.
Go ahead, Vicki.
I think where we've looked at that in the U.S. is the fact that it is cost savings to the health system. So although it may cost more, in the long run, when you look at hospitalizations and the cost to the actual health system, there is the savings there. And that's how then that case is made for, even though on the front end, I'm just going to cost me more, it will not cost you more on the back end.
I will caution, though, that the U.S. evidence is not well imported into Canada because of the uninsurance issue. So, you know, I'm happy to have a larger conversation about this. It's just, like I said at the very beginning of my statement, it is risky doing research. You're not always going to get answers that support your programs. You're not always going to get the answer saying that this is the greatest thing since sliced bread.
I just wanted to throw out a little bit of a maybe a taboo subject that we were discussing at our table last night, and that is probably related to the traditional power differential of physicians in the healthcare system. But there's a fair amount of subtle and not so subtle doctor bashing, if you will, that goes on. And I think that it needs to be recognized that physicians actually do have a lot to offer as far as clinical leadership. And it's not that there are too many doctors in community health centers, but there's not enough other team members, and there's actually, taken another step further, there's not enough other doctors working within community health centers, meaning, you know, fee-for-service doctors.
Before you go to the next question, in response to what you said about you're not going to always prove that what you're doing is the best way, and she is correct. One of the approaches we've taken also in the U.S. is, but that's okay, because then we know, and if we're looking at it truly as quality improvement, we need to know where we are so that we can test models moving forward so that we can improve. So you do have to be open to that and recognizing it's okay, but we need to know where we are. We'll deal with that, and then we're moving forward and look at it as quality improvement. And then if you look at it that way and you're actually committed to doing those quality improvement best practices and whatever initiatives you need to take and to account to make your system better, then it's a good thing.
And it really does matter what you measure. The performance indicators of doing any of these kinds of studies really matter, and there's a lot of political significance to what we measure. So if we're looking at, as long as full and comprehensive wellness is studied, mental health, physical health, and really trying to get a good hold of hospital data, it will matter in Canada, because one day in a hospital bed costs a significant amount. So that research has to be done really, really carefully, and the indicators have to be very carefully chosen.
I think one of the frustrations that faces CHCs and all sorts of community-based services is the asymmetry of standards applied. You know, you have to prove your case for comparative peanuts in the overall funding scheme that you're cost-effective, rigorous, blah, 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 and yet we have a staggering amount of inappropriate high-end care, diagnostic imaging. The Choosing Wisely campaign has revealed it, and the funding there isn't at risk. So I share your pain on this, but you know, back to Michael's yesterday render unto Caesar analogy, you don't get to set the terms of the accountability, unfortunately, unilaterally. So if you have to prove your case more rigorously than others, you know, that's the world you live in, and it's a Hobson's choice, but there you go.
At the end of the day, in Canada, it's the provinces that have jurisdiction over health. In our province, a few years ago, maybe longer than that, they initiated the Health Quality Council. And the Health Quality Council, as one of its elements of research, got interested through a provincial mandate in primary healthcare service delivery. And what they
decided to do is focus on a few key elements of primary healthcare performance, and two specific elements where how are primary healthcare providers managing diabetes and hypertension. There's a couple of other ones they added, I think, COPD and depression. I don't know how those are doing. You could voluntarily, as a group of physicians, as an individual physician, or the community health center, sign on to have performance indicators for hypertension and diabetes measured in your organization against that peer group of other people who chose to be measured. We are really interested in engaging that at the community health center in Saskatoon to find out, at the end of the day, how are we managing our hypertensions against some qualitative or quantitative measures, as well as how are we managing hypertension and diabetes related to our peers. It was a really exciting process to engage in, and we engaged in it with a lot of enthusiasm, and at the end of the day found out, relative to our peer group, that we were star performers in how we were managing those key indicators. I think that was valuable to us and continues to be valuable to us in terms of the case we can make that, in fact, our interdisciplinary approach to care is resulting in some a high degree of positive performance in some key indicators of primary healthcare service delivery. I think at a provincial level, I mean, you can, I think, and should advocate for your provincial governments to engage with you and other primary healthcare performers, whether they be group practices, individual practitioners, in setting some expectations about performance in some key areas of health, and have your performance measured against it, because you can really be informed and it'll really help influence you in how you strengthen your organization. Now, I understand the Health Quality Council isn't as much engaged in this kind of work as it had been in the past, and isn't sort of publishing information about performance in these areas, but maybe you could tell me, Steve, or other people in this room, how that's unfolding at this point in time.
Well, just be very brief. There's a cautionary tale in this otherwise excellent story. I was on the Health Quality Council board at the time. So we got organizations and fee-for-service docs to enroll in chronic disease management collaborative to improve, as Patrick said, in these areas. But of course, in the world we live in, the government figured it had to pay the fee-for-service docs extra to participate in the collaborative. Then the SMA negotiated with the government of Saskatchewan against all advice to say, you can have the extra fee and the extra without actually enrolling in the collaborative, as long as you tell us on an honor system that you're doing the pathway, and then that you will submit some data. So the minute the extra fee came off, nobody submitted any data anymore, except probably the clinic doctors. Right. So again, it's just it doesn't mean you shouldn't do it. I mean, it's better for your patients if you enroll in CDM collaboratives and do better at managing hypertension and COPD, blah blah blah. But again, it's the asymmetry of how this works out and why you need to be active in the policy realm about exactly how this works out and how does this apply not just to us, because the in fact comparison part of that's really quite an interesting tale actually about the quality. It's not only case making for you, but it's also, if it's going to work for the whole province, then the whole policy framework and whether you can do this cost effectively. And if all quality improvement ends up costing you a fortune, in other words, the general expectation is you show up and then you pay extra for every bit of quality improvement, your health system's going to cost $100 trillion in no time, right? And I know that sounds like a ridiculous thing to say, but that's kind of what the agreement that we've kind of made there. The quality's optional and you pay for extra, right? Like, it's just bloody bizarre. So what I'm going to do, we should probably wrap up here because we're, God knows where we are on the schedule. But to get out, to close this off by noon, I would just like to give our panelists one more crack at this question, if they're inclined at it, which is, given all that your experience has told you, given what you've heard and so on, if you could do one thing to advance the cause of measuring what matters, and it can be a methodological thing, it could just be turning your gaze on this, what would be your number one priority? Let's start with you, Jennifer, because as you live this.
I think I'd just start by collecting data and using it, because when you start using data, it gets better and you start asking more questions. So I think that's the biggest thing. We just need to start using the data, which makes us more curious, which makes us collect more data, and stop trying to make everything perfect, because as soon as you do that, you become immobilized and you sort of throw up your hands and say, this is too big, I can't deal with it.
You can probably guess what I'm going to say. I think you need to decide what you're standing for. Are you standing for community-based, very close to the community type of primary care? Are you standing for a model called community health centers, and are you going to continue to discuss what's a community health center or not? To me, as an outsider who relies on consistent definitions, it is strange to me that the Ontario Community Health Center Association has things that are not called community health centers under their banner. Either they're a community health center or they're not. I understand that they share a similar ethos, but then don't say that you're a community health center organization. Say you're a community-based organization. What is it that you stand for? Decide what you stand for and be consistent about how you say who is standing for that with you. And I'm starting to doubt that it's actually the model called community health centers. It's something else. It's something about that connection to the community that you have and that community responsiveness that you have, and you need a different label. That may include lots of things that are often called community health centers, but it may include other things. It may exclude certain community health centers. So I think you need to have a really rigorous conversation about what is it that you stand for.
Farah.
I think it's really helpful for community health centers to start developing research capacity, to set your own research agenda, decide what's really important to you, given your model of care, sitting around with your collaborative providers and your patients and people who see you, and ask them, so what are the questions you have? So once you've got your questions, then start developing ways to help answer those questions. Developing relationships with experienced researchers are one way. And developing your own capacity to do research. There's so many ways to learn how to do research. I spend a lot of my career teaching physicians how to do research. It's completely possible to be a clinician as well as a researcher. And in fact, it'll probably improve your practice. So being research friendly does mean that you're probably adhering to a higher standard than your colleagues in the acute care system. But what's wrong with being twice as good? That's what CHCs are really good at doing.
Good to see. So, Vicki, I just close with a question for all of you, which was if you could do one thing to advance the cause of measuring what matters, and you could embark on that tomorrow, what would you propose?
It would be to gain the buy-in and the commitment to stay the course, regardless of whether there's funding there or not, but to be determined to be in this room from now until 50 years from now, but be in this room actually deciding we're going to do this, regardless of whether funding is connected to it, regardless of what it takes to determine that we're going to decide what we want to do together, what measures we want, and what story we want to tell. But that commitment to me is the first thing that has to be there.
Well, that's a wonderful note to end on. Please join me in thanking the panel for a stirring session. And again, thanks to all of you for your vigorous contributions. So.